A very good afternoon, and thank you very much for coming to the seminar. My name is Abhijit Manaswi. I'm a joint replacement surgeon. I've joined as medical director for the joint replacement program. We have a brand new joint replacement center. It's on the 4th floor, and we have a whole dedicated team which includes right from operative and right from clinic. We have dedicated nursing, we have dedicated physical therapists, and we have a care coordinator who coordinates your care the moment you decide to have surgery with us. Now, I have been in clinical practice for over 9 years now. For 8 years, I worked as a faculty at the University of Oklahoma in the VA Combined Program, and I taught many orthopedic surgeons in training how to do knees and hips. So I have a lot of experience doing this. I'm fellowship trained in joint arthroplasty, and that was at University of Virginia in Charlottesville. And I've done a lot of these newer technologies in my practice. And what is different and unique in 2017 is completely technology based. Now, we love technology in our day-to-day life. We love smart cars, smartphones, smart watches. Likewise, in the joint replacement world, technology has taken over. Now, the value is that it removes the element of human error and guesswork. Things are based on computers for the knees and on robotic arm-assisted surgery for partial knees and total hips. And these are based on a pre-operative 3-dimensional CT scan. So we capture your unique anatomy, and all that is fed to the computer, which is the brain of the robotic arm. And during surgery, we identify the different bony landmarks and feed those to the computer. Now, what the robotic arm does is the computer processes all this information, and then it creates a virtual image which is unique to your anatomy. So it tells me the different angles in which the components need to be placed, and the robotic arm controls that. So you end up putting where you had planned to put. So this improves the accuracy. It eliminates the human guesswork factor. Now, all the studies show that the longevity of the prosthesis and the complications are directly proportional to the accuracy of placement of the components. If you put the components where they belong, for the hip, if you restore the center of rotation of the joint, your biomechanical frictional wear and tear is minimized. Likewise for the knee, when you recreate the biomechanical axis and then you balance the knee right, then that minimizes the torque, which means that an improperly done knee replacement or a hip replacement because of biomechanical reasons, which would fail in 8 years, 10 years, 12 years, all of a sudden, once you align it perfectly, you have doubled the longevity. So now we talk about 20 years, 25 years, who knows, maybe 30 years or more. We don't have that outcome studies yet, but sure, we are seeing significantly improved results in the midterm and in the short term once you recreate the anatomy. So my talk is about how we have used all the new technologies and brought this to this hospital. I'm the only person who does this robotic arm and computerized knee replacements in this county. We don't have any other hospitals participating or who have a surgeon who's trained to do this. And that puts us in a very different opportunity that we can do this for the community and give you the best possible outcomes based on the technology. So we'll move on. This is the parent company which makes this, and now it's owned by Stryker Corporation, and that's the only company which has the robotic arm technology. So I'll talk a little bit about knees and then talk about hip arthritis, and then we'll focus on how this has impacted the surgical process. So osteoarthritis of the knee is fairly common. There are over 500,000 joint replacements of the knee performed annually, and this number is projected to rise dramatically in the next decade. Now, the symptoms are typical. There is pain, there is stiffness, there is swelling, there is instability, there is limitation of activities of daily motion. Now, with that, we get more and more dependent upon our braces or walking aids, and our quality of life suffers. Now, osteoarthritis is the fundamental problem behind any kind of joint arthritis. What it means is that for some known but majority unknown reasons, we lose the cartilage in our joints. Now, cartilage is the natural shock absorber, plus it doesn't have any pain fibers, so we don't feel any pain as long as we have healthy cartilage. Now, when this cartilage thins out and gets eroded, then we start loading the bone abnormally. And those are seen as stress reactions. We also develop cyst in the process. We develop microfracture. The pain fibers in the bone get stimulated, and we get pain from arthritis. And you can see some of the data here that the volume of osteoarthritis is just going to increase in the future. Now, like most conditions, there is an early stage, there is a moderate stage, and then there's an advanced stage. So this is just a recap on our normal anatomy. We have the top bone or the thigh bone, which is the femur, and then we have our shin bone, which is known as the tibia, and in between we have a host of ligaments which stabilize this. And then we have the kneecap here along with the patellar tendon. Now, this here on the left is a normal looking. You can see that the cartilage space is well preserved. Now, as we develop arthritis, you can see that there is joint narrowing. Okay? So this is intermediate arthritis. Now, sometimes the loss of the cartilage thickness can be asymmetric. So then we develop bow-leggedness, which is very common. And especially in inflammatory type of arthritis, we develop knock-knee deformities, or we say a valgus deformity. Now, some of the known causes for cartilage loss are as sports injury when we were younger, any tear in the meniscus or cartilage will eventually lead to early degeneration. Any kind of long-term impact activities will result in cartilage degeneration. Obesity works by increasing the total force which goes through the joint. So normally when we walk, we put about 4 to 5 times our body weight through the knee joint. So if we have an excessive weight, say of 50 pounds, then you multiply that by 4 to 5 times. So the knee sees about 4 to 5 times of that weight every step we take. And this is more as we go into squatting or stair climbing or any kind of single-legged stance. Now, the traditional treatment has been weight reduction, quadriceps strengthening exercises. Then we have lifestyle modifications, like you avoid impact loading, squatting, bending. Injections typically work by reducing the inflammation, and cortisone is what there is some evidence to suggest the use of cortisone. But remember, there should be at least 3 months interval between cortisone injections. Now, there is a huge marketing promotion for viscosupplementation injections. Our academy, AAOS, they have published since 2011 lack of efficacy and lack of studies which support that they work. So we don't recommend it routinely, but if I have come across a few patients who swear and say that yes, the viscosupplementation worked. So I discuss all the evidence, and if they want to try it, I'm open to it, but they should understand that it's not backed by a whole lot of scientific data. Now, arthroscopy has got no role in knee osteoarthritis. This has been proven multiple times over the last 20 years in different literature around the world. So, but if you have a mechanical block or if you have a ligament injury, yes, arthroscopy will take care of that, but it does nothing to the osteoarthritic process. Now, knee replacement has traditionally been considered the gold standard. Now, it has variable success rates. Now with improved technique and with modern implants and plastic, now we say that anybody who's older than 65, he has a 90% chance of that knee lasting 20 years, 25 years or more. So that's very encouraging. But the key is the biomechanics has to be correct. Your mechanical axis should be nicely reproduced. Your knee ligament balance should be accurate. So those are the variables where there can be human error. And once we correct those errors, then suddenly you improve the patient satisfaction. Most of the studies show the satisfaction rate around 75–80%. But with accurate placement, you can improve the satisfaction rates as well as the longevity and minimize the complications. Now, this is with traditional knee replacement. Now, doing a partial knee replacement for a localized arthritis, this is very popular in Europe. In some studies in North America, we have seen good outcome data and longevity, but what happens is that there is a lot of element of human error because you base the entire cut of the bone on external jigs and they are not very accurate. So there's a huge variability in the outcome. So this has never been very popular because of this element of human error and variability. Now this has changed with robotic arm-assisted surgery. Now with robotic arm-assisted surgery, and I'll show you lots of pictures here, that you make the cuts as per your mechanical axis, as per the template. There is an arm which comes out, which is controlled by the computer, and it determines what you have to cut, how much to cut, what angles, what is the slope, how much thickness of bone you have to remove, and if once you map the bone, if you're outside that safe window, it doesn't work. So it eliminates the element of guesswork and human error. So some of the complications with traditional partial knee replacements, as you can see, is high failure rate because of human error. The technology is not bad, but we can't do it consistently with guesswork. Now, this is where we'll move to the next slide. So this is where Makoplasty comes. Now, this is the robotic arm. This is the same arm which is used for a hip replacement too. Now, what happens here is this arm is controlled by this machine. Everything gets draped in so it's sterile. There are some trackers which are attached here. And on this screen, you get these images. Now, this is based on the three-dimensional CT, and once you have registered the different landmarks. Now, this creates that unique anatomy which is specific to you. And this places the components exactly the way it should be done. Okay? So you can see here how you can change the different axes and make it right to recreate the slope, the varus, the rotation of the components. We never had this kind of freedom and information with the traditional technique. Now, you make a small incision for a partial, and there are some trackers which are attached through drill holes here to register the different points. This is registering the different points. Now, this image, this is how you register the points and then you confirm those points, okay? And it gives you this alignment. So you range the knee and it tells you how your knee will track, okay? Now, this is the robotic arm burr. So it tells me that this is the size of the component. The green area of bone is what I have to remove, okay? And the moment I go outside the safe zone, it becomes red. So even if you remove 0.1 millimeter, little bit of bone, less than a millimeter, it shows up as red and then your machine stops working. So it's that accurate. So you can see here on the tibia, which is the shin bone, it's asking me to create a pattern like this. And as you keep on removing this bone, the moment you remove a little bit extra, you see here, it becomes red. So that helps you be very accurate. Now, this is how the x-rays look after a partial. You can see here the inner half. This is how it looks. You can look that the mechanical axis is nicely reproduced. So what we consider is the center of hip, the center of knee, and the center of ankle. That should be in a straight line. And that's the goal of the surgery. And this is best done with modern gadgets, with modern techniques. Okay. So these are the huge advantages. Most of the knee replacements, which I do, it's all computer assisted. Okay, so we make the incision through a small incision. We go by the side of the kneecap. We split the muscle so that there is no scarring. Your tendons are intact, and all the bony cuts are taken without violating the medullary canal of the bone. Now that reduces the incidence of pulmonary embolism and clots. Okay, there is also less pain. There is less blood loss because the canal is not open. Now, the other thing unique with the knee replacement is that the femur bone is a curved bone. It's not a straight bone. It's curved in two planes. It has got an anterolateral bow from the front, and from the side, it looks like curved like that. Now, the traditional knee replacement is based upon one putting a straight rod, which is drilled into the bone, and then putting the jigs on that. So you can imagine that in a fair amount of cases, you'll be off because you're putting a straight rod in a curved bone. Okay? And as we develop arthritis, we develop curvature deformities of the bone. Okay? Both of the femur and especially in tibia. So anytime you do that, you are also adding to the malalignment by human error. You're not putting the components where they belong. And that's why we have outliers and failures, and the success is not that great. So every time you put your components in the right place, you have the best outcome. Plus what I do different is pre-operatively. Now this is supported by a lot of preemptive analgesia which has evolved in the last decade. So what we do is on the morning of surgery, you receive some pain medications. That blocks the nerves completely. So during surgery, when you have your pain mediators release, the nerves are already blocked. So your pain sensation is not that severe. The other thing is we do pre-operatively a selective adductor canal block. That blocks off all the sensory pain fibers coming from the knee. Plus during surgery, we have a cocktail of mixture of different anesthetics with a pain medication. Now, these are long acting. So what it does is, for the first, and I infiltrate about 100 cc of that in the capsule and in different areas where there is more concentration of pain fibers. So your experience post-operatively is amazing with no pain for the first 24, 48 hours. You start walking about 2 hours after surgery. Once your blood pressure is good, once you're off the anesthetic medications and you're feeling good, all your vitals are normal, typically within 2 hours of surgery, with the help of the physical therapist, you get up, you walk, and then you start bending your knee. And you get that same thing that evening and the next morning, next afternoon, and the majority of my patients go home the next day of surgery. So it's like 24 hours of stay. okay? And the prosthesis is designed to straighten your knee, and it can bend back to about 120 degrees. So I encourage everyone that straightening is easy. For the bending part, I restrict to about 100 degrees, 105 degrees for the first 2 weeks. And once the staples come off, then you get that next 10, 15 degrees of bend. Okay? Now, you're not hooked to any morphine drip or any PCA pumps, as a lot of places offer, so you don't have any nausea or vomiting sensation. So it's all controlled with oral pain medications. We encourage you to take it as needed after surgery, and all patients go home on these pain medications. You follow up in the clinic at 2 weeks, at 6 weeks, and by 6 weeks, most people are back on their feet and doing everything they want to do by week 4 to 6. You can start driving at 6 weeks, and then it's a 3-month or a 1-year follow-up. So it's with the help of technology, with modern pain control, knee replacement and hip replacements have changed dramatically. So I'll show you some more x-rays. These are some of the other studies, early outcome studies, where you can see that the satisfaction rates have jumped considerably, almost to 90% from 75%. Now, along with this, I also do a lot of complex deformities which are more involving, and some of these examples, you can see there's a bowing deformity with a valgus type which gets nicely corrected. These are more involved surgeries. These have longer incisions. Some of these are fracture malunions where computer is so handy, where you can get the axes right. These are again more complex surgeries, and you can do 2-part where you can fix the fracture and then come back later and do the computer knee replacement. This is knee instability because the ligaments were out. So this gets stabilized by more modern techniques. Sometimes you can have a lot of bony destruction from prior ACL surgery. So you can do cones and wedges and different modern implants to get around. This is a uni which was done with mechanical technique. You see how this has fractured and subsided. So this was done by using metal augments on one side and recreating the joint line. This is again failed uni from a lot of destruction. This is an older patient, so I chose cement to augment. Likewise, somebody where the ligaments are completely off, you need a kind of a hinge prosthesis here. Somebody with severe deformity and contractures, you can do more involved hinges here. Somebody with severe malunion, you can again do computer-assisted knees. Somebody with very little bone remaining to support a component because of multiple failed surgeries, you can remove all this and just do a distal metal femur. So this is everything about knee replacements. I'll talk about hip replacements and then we'll take questions. Hip replacement is has again made a huge difference in the way we have approached this now. Now, the symptoms are very variable, but typically we have groin pain, and sometimes you can have thigh pain or lateral pain or buttock pain, and it's important that we differentiate this from knee pain because sometimes they can radiate, and also from lower back pain. Okay, now the hip joint is a little different. It's a ball and a socket joint. So if I show you the model here, so there's a huge anatomical variation in the neck. Now, on both sides, traditional hip replacement is based on the assumption that the neck angle is typically at 10 or 15 degrees. Okay, studies have now support and suggest that that this version angle is very variable. It could be -10 and it can go up to +40, +50 in a dysplastic hip. Okay. The other thing which we have learned is that the socket is again dysplastic. Now the goal is to put 20 degrees and we base it on the local landmarks, but this gets deformed and there's a huge variation from patient to patient. Also, when we position the patient and we move the limb over, now what happens is that the muscles are connected to the pelvis. So anytime you move the leg over, the pelvis tilts. And if you're doing a traditional operation where you're basing it on local landmarks, you can be off. Because we rely on certain external jigs which are attached to the cup and to the reamers. And if the pelvis has changed, then we'll be off. So that's why there are more incidents of early failure, osteolysis, dislocation, and all this is more with traditional surgery because we don't know where the angles are, how the pelvis is placed. And this is where robotic arm makes a huge difference because this is completely based on CT scan. We do a preoperative CT scan, we know what the angle here is, and we mimic that angle here. Plus, preoperatively, we know what the leg length difference is. Okay, so there are trackers which are placed. One tracker is placed here, one tracker is placed here. Now, what we do is, before we dislocate, we register these points, so we know what the leg length is. And that is factored into our bony cut here. So we recreate and reproduce the exact length during trial, and we make adjustments. So we have a lot of live feedback during surgery as to what the problem was before we started. The other thing is, on the socket side, there are different points. There are over 300 points which we have to register. And that gets fed into the computer, and I'll show you all the pictures. And when we put our reamers, there is also a tracker in the pelvis. So if the pelvis tilts, the computer detects it immediately, and then it adjusts the reamer. So there's also, we know how much to ream because our goal is to recreate the center of rotation of the joint. And based on the CT and my registration, it will tell me how much more do I have to ream on the inner side, how much more I have to ream in the front, in the back, to recreate your unique anatomy. And this eliminates the guesswork. Before this, we just used to ream, okay, it doesn't look right, okay, let me ream more. You know, there was no clue, there was no guideline. And it just came with trial and error and with experience. But now everything is so precise. So it eliminates the scope of human error. So we'll show you. So anytime you are off, the reamer stops. And it again shows up as red the moment you start removing more bone. So I'll show you how this has changed our approach completely. Now, some of the common causes, we know osteoarthritis is the commonest, but rheumatoid arthritis is seen in less than 10%. There is inflammation and there's destruction of the cartilage. There could be other causes like hip fracture or dislocation. Now, there's a condition known as lack of blood supply to the head, which is called as the avascular necrosis. Vascular is blood and A is without, so it's without blood flow to the femoral head, and then it collapses. So this is seen predominantly in younger individuals, and then unfortunately some people are born with an abnormal bone in the hip joint, so it's not suited for low friction kind of movement, and because of lack of formation or malformation, there is more frictional torque and early degeneration and wear. We call it dysplastic. So osteoarthritis, as we know, is the commonest cause, and with the growth in the aging population, the numbers are going to swell up in the future. Now, it's very similar. You can see this is normal looking joint where you have concentric hip joint. There is good space. On the other side, you can see the joint space is reduced. There are large palpable, large spurs which are seen along with dense white lines, which are stress reaction from sclerosis. Now, this we have already discussed. So with traditional hip replacement, there was a huge issue of dislocations, leg length discrepancy, implant loosening, and accelerated wear. Now, implant loosening and wear is related to the accuracy of putting the components. So the biomechanical forces are more, there's more frictional wear and tear when the components are not placed right. And that creates microscopic wear debris, which in turn causes more inflammation, and it activates a certain type of cells known as giant cells. And they start destroying the bone, and we call this process as osteolysis. So all this is directly related to the accuracy of putting the components in the correct place. Now, this is a long list of all the complications which we see when the components are not put right. To you, it means poor function, more pain medication, early surgery. So that is how it translates to if the components are not put right. Now, this chart study is very unique. This was done at Mass General Hospital in Boston. Now, they used the conventional technique of cup placement, and they found that experienced surgeons were accurate only 47% of the time. This is the box where this is the safe zone, and you can see the outliers. It's just all over. This is worse than flipping a coin. Now, when the same set of surgeons used robotics, Makoplasty is the name for the robotic arm, you can see that 84% were inside the safe zone, and even the ones who were outside, they were very close to the safe zone. So this tells you objectively what technology can do, how it can improve the accuracy. Now, we'll move to some of the slides. So this is what we talked about. There's a specific 3D preoperative and intraoperative planning. We make the guided neck resection as per the leg length discrepancy you have. Now, the robotic arm controls, this reamer is controlled by this robotic arm. So it tells me what angle to put it at, how much to ream, how vertical is the cup. So there are a lot of angles in the hip which we have to look at. All that is controlled by this arm. Plus, when you put the cup, it again tells you how to put the cup, where to put the cup, and it measures the leg length and the offset, which means have you restored the center of rotation or have you put the hip more laterally on this side? Because then you'll notice that your bone is more prominent on one side or less prominent than the other side. So those are factors which we can accurately correct with this technique. Now, these are some of the intraoperative pictures. You can see this is what the computer is saying, that I have to ream here to make these points overlap. And it's telling that you have to put the cup in 40 degree of inclination, 20 degree of version, and in the process you have to ream the floor 4 millimeters, superiorly 1 millimeter, and you don't take out any bone in the front. We never had this information with the traditional technique. Okay. Now, we can also dial the cup where we want to and change this to improve the bony contact and maintaining the combined anteversion. Now, during surgery, as you ream, this green will disappear, and if you have reamed more, then it'll show red. So the moment it shows red, you stop. You know that you have hit the right spot. And then when you place the cup, it again guides you through. As you can see, it's telling you that this is how you have to go, and you can look at these numbers as you're putting the cup. Okay, in this process, it's saying that you're at 39 degrees and you had planned 40 degrees. So it's asking you to correct it by 1 degree. Likewise, it's the version, it's saying that you are putting at 18 degrees, you need to put at planned is 20 degrees. So then you go ahead and move the handle and look for the numbers. And when they are right there, you hold it, and then your assistant or yourself, you can bang the cup in. So that's how it has helped eliminate. And anytime and every time you do it, you always get the best outcome. You get very good looking x-rays, which are very essential for long-term survival and longevity. And because of the accuracy of the placement of the components, you can improve the implant survivorship by reducing the biomechanical torque and the force. Plus, all the issues of leg length discrepancy, dislocation, tissue tension, range of motion, everything gets better. Now, this was a small company, but it has evolved, and now it's purchased by Stryker, and now it's getting very popular. There are still very limited surgeons in Florida who offer this technology. Along with some of the straightforward hips, I also get a fair share of revisions, redos. These are all my cases, and you can see, depending upon the deformity, there are lots of options, and everything can be CT scan based, as in this case with the custom cup for complex revision, or you could just change it with a different implant. This is fracture with dislocation. So there are lots of options you can do where there is a lot of bone loss and there is not enough supportive ring. You can do a cage and do a constrained liner. Likewise here, where there is no roof because you have lost this bone here, you can put the head in that area and fix it with some screws and just put your components there. So these are some of the challenges which we come across on a day-to-day basis. But the good thing is that with smart implants, with modern technology, it makes us more reliable, it makes us more accurate, it helps us eliminate the element of human error, and it's all designed to improve outcomes, reduce complications, so that your joints last forever. So thank you so much for your kind attention.